Actual service. Well, I've taken Rachel's service in South West London. They haven't completely, well, they haven't in 2008 anyway, completely got IPS into all their teams, even after 10 years. So it wasn't something that just happened, not like instant coffee, not like put in and pour hot water. But they had 11 out of the 18 teams, and 1,100 people in work or mainstream integrated settings. But look at the numbers. Of course, there are people in employment, in education training, people in mainstream voluntary work, but actually by far the greatest number, which is not what you'd expect really from most services, by far the greatest number are in paid employment. Median number of hours worked, 25 hours per week, so people who are actually over the 16-hour base. Some people in education and training, some people in mainstream voluntary work. Quite impressive. But this is where I think you start to kind of delve down into why this is happening. On the left-hand side, you see what the situation is really what I would call a kind of ordinary run-of-the-mill service with your community mental health team and your OT there doing a bit of employment work. And possibly access to an employment specialist somewhere within the service. Where you have, and this is South West London, an OT plus a quarter of the supported employment worker, then your outcomes are struggling. You're sort of getting somewhere around 20%, a bit less in other settings. Double that, half a employment support worker, one worker per 2 teams, and already your education and your employment starting to go up. Go for the fidelity model where there is one employment specialist per team, and over time, the numbers in employment really do dramatically improve. And this is where I think you start to think, well, actually, perhaps, you can't do this in a half-hearted way. Those are the results over the same period for one of the teams where they hadn't introduced IPS. I won't dwell on that, but you can see that things are pretty flat there. This is one of the most interesting slides for me, actually, and it's where I think things are going to go quite a lot in the near future. In the typical early intervention service, first episode psychosis, this kind of thing, younger people, then at first admission, about half are in employment or most likely in education, which drops to about 20% after a year. In other words, the norm is for people to lose their jobs or drop out of college or whatever. Put an employment specialist in your early intervention team, and the picture is very dramatic. After 6 months, then you start to see, not that it's falling off, but that actually it's starting to increase. And the longer it goes, the more people stay in education, the more people young people gain employment. Some of the most spectacular results for IPS have been with younger people with first episode psychosis, which makes sense really. It's the people who have not lost hope, the people who have not reconciled themselves to a lifetime's career as a mental patient, the young people who want to lead the kind of life that they've always aspired to lead, and you give them the chance right at the beginning, and it really does seem to work. And this is what Bob Drake says. Following people for 30 years, and then following patients in dozens and dozens of research studies, it's totally clear to me at this point there's nothing about medications or psychotherapies or rehabilitation programs or case management programs or any of the other things we study that helps people to recover in the way that supported employment does. Now, he's an evangelist, you can take that how you like, but he's also a very experienced and respected researcher. So, what's happened about this overwhelming weight of evidence? Well, actually, interestingly, in England at least, it's been reflected over the years in policy documents quite a lot. We've had a whole slew of policy documents. The first one where it was explicitly recognised was the famous Social Exclusion Unit report, which I think probably was one of the most influential documents. I'm not quite sure, and forgive me because I don't know how far these things permeate into Northern Ireland. But I suspect across the UK it was pretty influential. People quoted it a lot, and actually what it demonstrated was just how excluded people with these severe mental health conditions are from employment and from everything else really. And in this, it was explicitly recognised for the first time in a policy document that actually there was an alternative. There are ways of improving this situation, at least in terms of employment. The Department of Health even went so far as to issue in 2006 some commissioning guidance saying basically if you're going to commission employment services, then take some notice of the evidence base. I don't think many people did, and it kind of stood there on the shelf and everyone referred to it, or people like me, but it didn't really happen. And then in 2009, last year, 4 documents were issued simultaneously. Not all of them Department of Health. New Horizons, which was the then mental health strategy. A piece of work that Carol Black and her team did, and which I was involved in, the mental health and employment strategy. A very important piece of work by Rachel Perkins. Funny how Rachel name pops up again, for the TWP, herself, Paul Farmer from mine, and Paul Litchfield, who's the Chief Medical Officer of BT, did a review of the most excluded people in the mental health field. And Work Recovery and Inclusion from the Cabinet Office was the response to that. And in this, Rachel and her team set out very clearly what needed to happen in policy terms and in practical terms. So you would think that we'd have services all over the place suddenly, magically following the evidence base. Well, of course we don't. And that's because actually you can, it's a bit like research really, you can publish your research papers, you can publish the policy documents. Something else needs to happen. It's all very helpful. Something else needs to happen that is actually going to go. Now, there's one forthcoming. Maybe useful, we'll see. We've nicknamed it in the mental health field Blue Horizons because it's a kind of, it's the coalition's policy document. We thought New Horizons, Blue Horizons. And what I understand from this, and I've seen, perhaps I shouldn't, I've seen some early drafts of it, is that one of the outcomes that will be required from mental health services in England is for people to count employment outcomes for people using secondary services. Counting what you actually do, what actually your outcomes are, is probably one of the most powerful agents for change. And if you are measured by that counting too, then that is even more powerful. And that's, I think, something a little bit of light and a little bit of blue on the horizon, hence Blue Horizon. We'll see. So, plenty in policy documents, but not a lot in practice. What do you need then? What happened? Why is it that we do have some services? Well, and this is distilled from a number of pieces of work, including those from Becca, from Miles Rinaldi and Rachel from South West London. The change is not just the change in the service provider, and that's the sort of the first thing to be said. Actually, what you have to do is to get the commitment not just of the service provider, but of the whole mental health system in the area you're talking about, which starts with the people who commission services and the people at the top of those who run them, the chief executives of the trust. And that, therefore, sets the tone. That means that people in every part of the system take notice. And that's what they did at St George's. They had, not only did they work with their commissioners, but they had actually a trust board committed wholly to giving greater priority to employment. You need inspiring leadership. You need someone who's been there and seen how it can be done to lead the process, and Rachel was that. There are others in other parts of South England. We have a very inspiring service in central and northwest London, which Lynn Miller has started with a lot of help from her trust board. Jan Hutchinson in South Essex. Martin Dominey in Sussex, really starting to get some people who've actually gone and looked at services that work, come back and said, we can do that. And you need to make changes, structural and organisational changes where necessary. Sometimes you have to take hard decisions. You have to say, well, we can't bolt this on. We have to stop doing some things and start doing others. You have to think about what the composition of your community mental health teams are. Do you really need 2 occupational therapists? Can you have an occupational therapist and an employment support worker? Can you have a member of your team structurally who is obviously accountable to the team but also accountable to the employment team? Can you start to really muck around with what is a clinical preserve? And of course the answer is you have to. So it's a whole organisation thing. What about at an operational level? Well, it's a selling job. You have to actually achieve commitment? Firstly, of course, you have to work with your service users to do it. We did a piece of work in Surrey a little while ago, helping them make this transition, led by the commissioners, but with also the trust and with the voluntary organisation doing it. And the team that we worked with was a team of service users. They were the people who were commissioning the services that they were going to use. And that was very important. You have to sell this. It's not an easy thing to tell people the service you have and which you're quite comfortable in, that you like, perhaps needs to change. Perhaps it can't happen anymore. Because actually you need to start doing other things. But very, very difficult. And of course, others. My phone is switched off. I won't bang on about that. Recovery-oriented mental health services. Actually, I think recovery and what I've been talking about is entirely compatible. Recovery, as you will know, and as I'm sure you've heard from previous speakers, it's about helping people who have mental health issues, who perhaps still have them, and have them periodically in their lives or all the time, but are nonetheless determined to lead the kind of lives they always wanted to lead, to recover your life, not recover from illness in the conventional sense. And if the services that you run are dedicated to that proposition, then employment starts to become very important. You also need, and this is something which I've learned over the last year, most strongly really, which is that you can't just train your workers, plonk them in an office and say, there you are, you're an IPS worker, get on with it. You have to actually create an environment where they can learn their trade, where they can be closely supervised by people who know what they're doing and who are paying attention to their outcomes as well as to their process. And continually refreshing that, continually challenging. The fidelity scale is very useful here, because actually it can be done in a way that is not frightening or threatening. We go around sometimes doing fidelity reviews for teams just so that they can help themselves focus from an outside perspective on what they do. And the idea is that they wind up feeling fired up and determined to improve, not crushed by what we say. And it does help. It does help if you have objective ways of scoring what you're doing. And it also helps if at least once a month, but preferably once a week, you have actual case-based discussions about your caseload. Supervision, terribly important. And of course, continual evaluation, monitoring of outcomes and process. It's a very thoroughgoing process. It's something that is not taken on lightly. It's something that, however, nonetheless, when it starts to work and when people see the results, that people start to become very, very committed to. Never in going around our centres of excellence, which is the programme that we run for the 8 or 9 trusts, I've never come across any of the workers who say this was a load of all rubbish. They all say, oh, my professional life is getting towards now where I want it to be. I'll just say a bit about the Centres of Excellence programme. We called it this not because we think that the people, or they think indeed, that the services that we call in our Centres of Excellence programme are all excellent. They're not. They're all learners, just like me, just like Jeff Shepherd, just like Rachel. We're all learning. We're all on this journey. But they aspire to high fidelity services and great outcomes. And that's the qualification. We help them with fidelity reviews. We help them with specialist training. We have a very good website and a very good information officer called Jenny Bacon, who is very happy to answer questions. So if you do have questions on evidence or what's going on in the world or anything, then do email Jenny. I mean, we try to offer this service as the Centre, as the Centre for Mental Health. The best thing we ever did, I think, was to go over to Dartmouth. And they have and have had for a number of years in the United States what's called the Johnson & Johnson program, because it's sponsored by the